In this podcast episode, we discuss clinical trial updates in chronic lymphocytic leukemia from the 2025 European Hematology Association Annual Congress and the 18th International Conference on Malignant Lymphoma. This discussion is hosted by Dr. Constantine Tam, Head of Lymphoma Service at Alfred Health. He is joined by our guest, Dr. John Gribben, Consultant Hematologist and Medical Oncologist at the Barts Cancer Institute, Barts NHS Trust, as well as Dr. Stefan Stilgenbauer, Medical Director of the Comprehensive Cancer Center Ulm and Head of the Division of CLL in the Department of Internal Medicine 3 at Ulm University. Hope you enjoy it.
Hi, I'm Dr. Con Tam. I am a hematologist at the Alfred Hospital in Melbourne and a professor of hematology at Monash University in Melbourne. And we are discussing the updates in CLL treatment presented at the 2025 EHA Congress in Milan, as well as the 18th ICML Congress in Lugano, Switzerland. Joining me are my other guest, Dr. John Gribben, consultant hematologist and medical oncologist at the Barts Cancer Institute, Barts NHS Trust, as well as the professor of medical oncology at the London School of Medicine, Queen Mary University of London in London, UK, and Dr. Stefan Stilgenbauer, professor of medicine and medical director of the Comprehensive Cancer Center Ulm, as well as the head of early clinical trials unit and head division of CLL, Department of Internal Medicine 3 at Ulm University in Germany. So an eminent international panel of CLL experts. Many studies in CLL presented at EHA and ICML this year investigate the role of BTK inhibitors, BCL2 inhibitors, as well as new agents in various combinations. And we're here to really highlight the key results of these studies and how they might influence practice. So I might just start with you, John. So amongst the CLL abstracts presented at the Summer Hematology Congresses this year, which studies do you feel had the most impactful results?
Well, I know Stefan's going to disagree with this one because we've already discussed this offline, but I really liked the FLAIR study, not just because it's a British study and I'm on it, but I really do think what we learned from it and what the study is about really is about using MRD as an endpoint to determine how and in what way you treat patients with CLL. I think it's difficult because, as we're all aware, MRD is not routinely used to monitor patients with CLL yet, even though, of course, the technology has been around a long time. But what's innovative about this study is not how the patients were treated, but the way in which they were monitored and the duration of the therapy. And basically, the longer it took a patient's MRD level to drop and become undetectable, the longer you continued on the therapy. So you adapted the therapy by the MRD response. So I think what we learned from this study was that fixed duration therapy, in this case with ibrutinib and venetoclax, can be a very effective treatment for CLL. That we knew. That this can drive very deep MRD responses that we also knew. But what's, I think, novel about the study is the way in which you adapt the individual therapy to an individual patient. So this is a true personalized medicine approach that you, the duration of the therapy was based upon how the MRD was changing. And two things about it. Of course, we're used to seeing in other studies we'll talk about with the ibrutinib and venetoclax. I'm sure other studies, of course, looked at the same combination. But what we do know is that's usually a 1 year fixed duration. And when we look at the MRD responses in FLAIR, we see that a significant proportion of patients don't become MRD negative at 1 year, but take longer than that to become MRD negative. So the concept that we can have a fixed duration therapy, which is the same for everyone, I think is something that FLAIR tells us isn't really true. Now, of course, the other response would be, well, you just give the 1 year fixed duration. If or when the patient relapses, you can retreat. But if we really want to be, and particularly as we get new and better agents and come in to be using triplets rather than doublets and other things, the concept that we should be driving these patients into the best response and getting the most durable responses possible does suggest to me that, using MRD to do so can be very useful. Now, of course, we're used to using biomarkers like this in other diseases like CML we've been doing for many years, acute lymphoblastic leukemia we now do, acute myeloid leukemia we now do. We've got very robust methodologies that the ERIC organization have now fixed to be able to do this in CLL. So I don't think it's beyond us to be able to do this, but I take it very much so that this was an academic study with a single center doing the MRD assessments and directing the therapy. And maybe as specifically done in FLAIR, this is a difficult thing to do, but I think it is potentially feasible. And I think what we learn from this study is not one treatment fits all.
Yep. Thank you, John. So I think this is a really important study that we should just highlight in detail for our audience a little bit later, but I think the concept is absolutely interesting. Stefan, for you, what would be your top highlights apart from FLAIR at the conferences?
Well, I think, as John has said, I think FLAIR is a very important study, and I think the degree of disagreement that we have on it is not that stark. I think a problem that I'm having is that this MRD-guided treatment needs some more refinement. We know that patients with mutated IGHV achieve less MRD negativity, i.e. are treated longer, and yet their outcome is anyway better, while patients with unmutated IGHV achieve more quickly and more deeply MRD negativity, i.e. may be undertreated. So I think we need some refinement. And a key problem I think I'm seeing is that this MRD-guided treatment duration is, strictly speaking, not licensed, okay? And it's the 1 year treatment duration that is licensed. So I think there are some issues. Nevertheless, I think FLAIR confirms what we've seen from Captivate for young patients and from GLOW for elderly patients, unfit patients, that IV is a very efficacious and mostly well-tolerated treatment option. Sure, from GLOW we have learned we have to take care not to treat patients with cardiac comorbidity, with severe coexisting cardiac conditions, because they are at risk for higher grade arrhythmias. But for young or cardiologically fit patients, I think ibrutinib plus venetoclax has been proven in several trials now to be a very efficacious and well-tolerated treatment, and the body of evidence is very good in that respect. Beyond that, I think we have other updates on time-limited treatments, for instance, the CLL13 or Gaia study, where the venetoclax-based treatment options have also been taken forward and been proven, in particular when combined with obinutuzumab, that they are superior to chemoimmunotherapy and produce very good long-term outcome for the vast majority of patients. And some more experimental aspects I think we touch upon later in our program, novel ways to target BTK or other molecules. And I think, probably we touch upon that during the discussion at a later time point.
Right. So maybe let's talk about, let's put FLAIR aside as a sort of long-term semi-fixed duration therapy. Let's look at the updates of the fixed duration therapy. So we're going to talk about Gaia. We're talking about the long-term Captivate update. We're talking about the RMD or zanubrutinib van from Sequoia. I guess an interesting note, of course, is that with the further follow-up, that the triplet in Gaia is now actually performing better than the doublets, whereas the earlier follow-up suggests that IVO and VO perform similarly. Do you think that sort of should influence us to lean towards triplet therapy rather than establish oral doublet therapies that we have? John, what do you think?
Yeah, and I think it's absolutely fascinating. I think most of us were a little bit surprised when we saw the early results from Gaia that were probably not what we expected. And I think it also goes to show how important it is to see more mature data when we're actually going to make conclusions about these studies. I think most of us expected that a triplet would probably be better than a doublet. And a little bit obviously is going to depend on which BTK inhibitor we're using and which antibody we're using. But we've got data now from a number of studies suggesting that the addition of the antibody to a BTK inhibitor can deepen the response. So I think I was expecting this result. And I think the surprise is not what we're seeing this year, but the surprise is what we saw in earlier years. And I think it's particularly the case, of course, when we are talking about fixed duration therapy. It makes sense to believe, as we were discussing earlier, the deeper the response and the faster that response occurs, the more durable is likely to be the duration of that response. So I think it's logical that it would be this way. And for me, it was very heartening to see the results come out the way that we saw.
Yeah. Stefan, you comment on the sort of the new outcome in Gaia with the triplet versus doublets?
Well, I think, there about Gaia, there are 2 or 3 important points. It confirms, first of all, that venetoclax antibody combinations are also a very good treatment option, very efficacious in young and fit CLL patients.
Yeah.
Secondly, obinutuzumab is clearly the better antibody in CLL, also when combined with venetoclax, because there was a direct comparison to rituximab in that trial. Thirdly, and this is the interesting thing about the update that we see now, that indeed the triplet, when adding ibrutinib to obinutuzumab plus venetoclax, produces a significant PFS advantage. Now, sure, this comes at the price of also an increased AE rate, but the information that we have now is obviously that in patients where we are willing to accept that higher AE rate, i.e. patients who are probably younger, fitter, do not have such a history of infectious complications, we may well take the risk for the sake of beneficial efficacy to do the triplet, with the caveat that, again, this combination, strictly speaking, is not licensed.
Yeah. I guess if you look at the triplets, obviously the other triplet versus doublet, chart there is, of course, amplified, looking at AVO versus AV, where the triplet, once again, is better in terms of progression-free survival, but both Gaia and Amplify show really no differences to overall survival and increased toxicity rates for the triplet. So I guess a question that's still not clear in my mind is: are you better off using your triplet up front, or will you get equivalent result had you given a doublet and then given, let's say, the BTK inhibitor at the time of relapse, and would you have an equivalent outcome?
I'm a great believer that we really ought to be using our best therapy first.
Sure.
I think you see the longest duration of responses when you use your best combinations first before disease resistance occurs. For a long time, there were people who believed that, you keep the best for later on. But I think what we've seen over the years is that when you get a combination that works well, when you use it first is when you get the very longest response. And given that we all believe that since we're not curing any of these patients yet, we're looking to have what we want for our patients is fixed duration therapy to allow the patients to be off therapy for the longest period of time. To my sense, making getting the very best response with the best therapy at the present time, I would say, with all the caveats that Stephen says, of course, not being fully licensed yet, although, as Gad argued, Amplify is coming probably sooner, is that we would be wanting to use that. Now, if we look, you mentioned, of course, Con, about the issue of infectious rates, and of course, there were some concerns, but of course, many of these studies were done and performed during the COVID outbreak. And if you look at many of the serious adverse events and the deaths that occurred from infection, many of those were from COVID. And not that COVID isn't there anymore, but we're beyond the worst of the pandemic. And I think We've got to look at those results and understand that those studies were done during the worst pandemic we've seen in 100 years. And we've got to be able to say, you take that away and the infection rates really don't look that terrible. And I would argue that, in fact, if you used fixed duration and have a patient have a good, very durable response off therapy, their overall time on therapy is going to be less. And then the infection risk over that 10-year period is actually probably significantly lessened by using your triplet combination up front and then giving people very long periods off.
Yeah, I think I would agree. If we want to use a triplet, and there's good reason in some patients to do so, I think, as John, as you said, we should use our best weapon first. In particular, since with our first treatment, we on average achieve kind of an 8-year treatment-free or response duration or whatever you want to call it. And after 8 years, after frontline treatment, obviously the average CLL patient is in an age range where probably a triplet is less appropriate, I'd say, later on. And also, if we believe that with FCR already we had a cure fraction among our patients, we know that with venetoclax plus obinutuzumab or similarly efficacious regimens, we achieve higher MRD rates, MRD negativity rates. So therefore, we should believe that also with this regimen, there could be a cure fraction. And why not, try this in the first attempt? Because if we try it later, I think we all believe it won't be more efficacious.
That's great. Maybe let's move past the triplets and look at the sort of longer-term data of the doublets then. So we've got Captivate with IV. We obviously had the data Amplify that we saw at ASH, and now we've got the ARMD data with Zanu, with Sequoia. John, what's the impression between the doublets? Do you think they're roughly equivalent? Do you see any differentiating factor in the first versus second generation BTK inhibitor when using a doublet with venetoclax?
Well, I think when you mean by doublets, you're talking here about a BTK inhibitor. One, we're not talking about venetoclax or obinutuzumab. I'll come back to that, I'm sure, later.
All right.
But I think when we're using a doublet that's talking about a BTK inhibitor plus venetoclax, I think we've got more data and more durable data with ibrutinib plus venetoclax. But of course, we've now got data from using acalabrutinib in doublets and triplets. And we've, of course, got zanubrutinib data from doublets from Sequoia, and data that will come with doublets with sonrotoclax instead of venetoclax with zanubrutinib to come later. I think it's difficult to do comparisons head-to-head on these sorts of studies because, of course, they're done at different times in different patient populations with different inclusion and exclusion things. But I think the issue is it's likely to me that the second-generation inhibitors are going to improve the safety of the combination. I think we've all seen somewhat disappointing toxicity in the GLOW patient population, even though I think most of us think this is a very good combination to use. But of course, the Captivate data really suggests that in a younger, fitter patient population, the ibrutinib venetoclax combination is very effective. But I do believe that we've moved more and more away from ibrutinib onto acalabrutinib and zanubrutinib as second-generation BTK inhibitors for our routine use if we're using monotherapy. And I think it makes sense to believe that we will see better long-term outcome using second-generation BTK inhibitors in combination with venetoclax going forward.
Stefan, your view on the choice of BTK backbone?
Yeah, well, absolutely agree with John. Ibrutinib in the combination with venetoclax produced among elderly unfit patients a low number, but obviously relevant and tragic number of adverse events, deaths. And sure, the second generation BTK inhibitors should be better. On the other hand, we were a little bit disappointed with the early efficacy data that we saw with the acala-venetoclax combination in Amplify. Now, zanubrutinib combined with venetoclax, to me, looks better. We obviously do not have a comparative trial. And I would think I'm looking very much forward to the combination of zanubrutinib plus venetoclax. So kind of a next generation BTK inhibitor plus a next generation BCL2. And as we know, the phase 3 data is underway with a trial fully accrued with that combination. And I think we can look forward very much to the results, because this could truly be a novel, very promising option for our patients.
Great. So maybe I can take you guys back to the highest risk patients, so the 17p deletion patients, because we often talk about the doublets and the triplets doing well in standard risk patients. So we do have the update on continuous BTK therapy from zanubrutinib from Sequoia in 17p disease. And there is also a small number of patients with 17p disease who were enrolled in the doublets and the triplets, actually. What is your view? How do you treat 17p patients these days, John? And does the data present at EHA?
Yeah, I mean, this is the one patient population that I don't use fixed duration therapy on. This is the group of patients whom I think the data do support continuous therapy. And I agree that I think the safety profile and the results we've seen on the studies suggest that zanubrutinib might be the optimal BTK inhibitor. And right now I'm using zanubrutinib as a continuous therapy for a 17p deleted patient upfront. And I think the results from Sequoia, the arm, which was the 17p only, a relatively limited number of patients, but I think it is impressive. And if you look, for instance, at the 17p deleted patients in Captivate, where you're using the doublet, I think the 17p deleted patients are the patients that do continue to relapse, and the groups of patients that I think need not a fixed duration, or at least not a 1 year fixed duration as we've been doing it right now, but I think require longer duration therapy. And to my mind, zanubrutinib looks like the safest of the BTK inhibitors if you're going to be using it long term, particularly if you're going to be talking about using it long term in a younger patient, where you can start to be concerned about the very long term toxicity of patients on it for a very long time.
Stefan, how do you treat 17p patients?
Well, I think I agree again with what John has said very much. On the other hand, in the usual polls in our symposia that we are doing, where one answer option is I don't know or I am unsure, I would tick that box, because as we know from many phase 3 trials, these patients were excluded. And we certainly, for this population, it is not only the smallest, but it is also because they were excluded from many trials, we have the smallest body of evidence. Con, I mean, my concerns about Arm C of Sequoia, where I think there's pretty strong evidence that the 17p diagnostics were not adequately performed, so that probably not all patients in this arm truly had a 17p deletion. Nevertheless, efficacy looks very good, tolerability looks good. We know from Alpine that in this population in particular, there appears to be, in the relapsed refractory setting, superiority to ibrutinib. So indeed, continuous BTK inhibitor therapy appears, from all the evidence that we have, albeit limited, to be the preferred treatment option. Although I'd say, if there is a patient where you are concerned to use a BTK inhibitor as a continuous treatment, i.e. they are on anticoagulation plus antiplatelets, or have cardiac issues, or, just didn't tolerate that treatment well, I think you could still argue that time-limited venetoclax-based combinations are also a good option. Certainly not chemoimmunotherapy anymore, but we have choices, I think.
Yeah, but I think we're very lucky to actually have so many good choices. And I do agree. I think in a patient who is intolerant of BTKI, or where there's a contraindication, venetoclax-based options are actually fantastic for this population. They certainly respond. They will have a shorter progression-free survival compared to the non-17p population. However, at the time of relapse, these people in general do not carry resistant mutations with time-limited therapy. So there's no biological reason why you have burned the bridge, despite the higher risk genetics. And this with reference to the 17p diagnostic for Arm C. Sequoia, as Stefan pointed out, it was done by a FISH probe as his standard practice at a 7% cutoff. But we do know that the FISH probe for patients with low deletion percentage of FISH, some of them may in fact be overcalled. So arm C Sequoia has a relatively lower proportion of people with a concomitant p53 mutation, which is often a good sort of sense test for how high risk the population is. And it does have a relatively lower proportion of patients with p53 mutations in arm C compared to some of the other studies out there, but the patients were diagnosed, in a standard manner. Perhaps let's talk about FLAIR, because I really found FLAIR to be a fascinating abstract, and we've already spent time on it. But just for the audience, so this is the latest presentation is continuous ibrutinib versus a MRD guided I+V approach. And I think the headline results were the MRDs. The MRD, as John pointed out, is basically double the time from when you reach MRD negativity. So if you reach MRD negativity at 1 year, then your total duration is 2 years of treatment, which compared to Captivate and other fixed duration therapy results in a relatively longer exposure to doublet for the entire population. So there were patients at, let's say, 6 years, about a quarter of patients actually still on drug at 6 years. So the headline results are fascinating and to me completely unexpected, because we've got not only an improvement in progression-free survival using the MRD approach, but there's actually an overall survival advantage compared to ibrutinib. And that to me is really surprising. So Stefan, I know you've said that this is all, obviously this is single center, there's a lot of expertise involved, it's not a standard therapy. But to you, that does not suggest that, we have not actually optimized our CLL treatment just yet. And, in a big, brave world where we can get everything that we want, maybe an individualized MRD guided approach does give us the best outcome.
Yeah, absolutely agree. Maybe to the caveats with regard to FLAIR in the IV arm, I mean, it's not only that it was done in a specialized center that knew what they were doing and so on and so forth. I mean, the curves look like this was a 3-arm randomized trial, FCR versus ibrutinib continuous versus MRD guided IV, but that wasn't the case. Ibrutinib continuous therapy was in an earlier trial phase, and then the trial was amended later. Actually, the inclusion and exclusion criteria were amended. Patients with cardiac comorbidity and so on, based on the CLO experience, were excluded. So I think, the difference between ibrutinib continuous and IV MRD guided in FLAIR may have some other causes that may result from trial conduct. This is, I think, a bit of the caveat that I would see, that it is not a true triple arm randomized trial that compared these options. But in any case, we will get more evidence on that question, in particular from CLL 17, which we'll read shortly, and indeed did a 3-arm randomized comparison with 2 arms, including again these options, not MRD guided. And secondly, what appears a bit counterintuitive to me is to continue that very treatment that resulted in a suboptimal MRD response. If you were to modify treatment and change to another compound, i.e. use a bispecific or whatever, I'd understand the principle more. But to just continue a treatment in a patient where there's suboptimal response is, I mean, to me, not at least the optimal theoretical concept.
If I may just interrupt slightly, I would hate to disagree with you, Stefan. We very seldom do disagree. I'm not really disagreeing here, but I would agree with you more if it wasn't for the fact that the vast majority of the patients who don't achieve a rapid MRD response, still vast majority of them eventually get there if you continue the therapy long enough. So it does appear as if they're both, they get there. The other interesting concept, of course, is how the unmutated patients actually get to MRD negativity faster than the mutated patients. Also perhaps a little counterintuitive, except you might believe that cases that kind of proliferate more rapidly, maybe more responsive to the therapy in some way. But you're right. I mean, in studies we've seen before, if I remember correct, Con, you remember much better than we did because you guys led the study more. But in venetoclax rituximab, the duration of response was fixed on the fact that the vast majority of patients were hitting their MRD negativity and then plateauing within the time frame in which it was looked. That kind of analysis hasn't been done for CLL14 or for the triplets. We've kind of adapted quite often to think that 1 year fixed duration therapy, which made perfect sense to me and certainly produces very durable responses. But if you look at the data that was presented in the meeting and look at the time to MRD negativity in the peripheral blood, and you look at it by the mutational status and you look at the time to which this occurs, those suboptimal patients, as you direct, Stefan, eventually, for 95% of these patients become MRD negative eventually over time. So we aren't seeing that kind of pattern to suggest that these patients are becoming resistant to the therapy, just that we don't fully understand the reason why it takes them longer to get there. They still are responding because more than 90% of the patients become MRD negative if you continue the therapy. The other thing, of course, that begs the question to be, unless we're talking about a triplet, so if you've got that suboptimal response and with our two best classes of agents, what class of agent do we add to get that deeper response? And of course, the one that I guess we started off talking about, and the one we will get the answer from Gaia from, is whether or not the addition of the obinutuzumab really drives those responses faster. And with a triplet, maybe a shorter duration of response will be okay, because we will see those MRD negative rates occurring much faster by using a triplet than we do with a doublet. Well, of course, the other thing that we didn't talk about and we don't know because it hasn't really been studied yet, of course, is if you give I plus V for 1 year fixed duration and then 3 years later go back and give I plus V, or maybe 5 years later go back and give I plus V again, you may get the same duration of response as giving it as 2 or 3 years continuously. So we don't know for sure that flare is the way to go forward. We'd have to see what happens when you retreat these patients to see whether you get the same response. But I think most of us believe that probably the durability of a second line therapy, which is exactly the same as the first, is probably going to be shorter. So, yeah. But we've just got to see. I think pretty reassuringly, though, was not seeing the emergence of BTK mutations occurring with the doublets. I think that in itself shows how the addition of venetoclax really stops that mutation occurring.
So we might move on beyond frontline. So let's look at the new drugs that are presented beyond frontline, because we now have data on some of the reversible BTK inhibitors apart from the ibrutinib, and we also have some data on the degraders and bispecific antibodies. John, what do you think are the key highlights, so beyond frontline, in some of the new drugs from your point of view?
Well, I think all of us are becoming increasingly impressed with the results we're seeing with the degraders. I think two things stand out to me when I look at the degraders. First is the safety profile. They appear to be very safe indeed, which is also very heartening to see. And we are seeing responses occurring in those patients who've already acquired mutations that occur from, other BTK mutations. What we don't have yet are really the durability of the responses to say, how good it's going to be. I mean, we all know that pirtobrutinib can induce responses in patients with BTK, the standard BTK mutations we see with covalent BTK mutations. But I think most of us would agree that the duration of sort of responses are somewhat disappointing. And in that kind of second year, many of those patients relapsing. We'll need more and longer data to be able to tell us whether that's going to be true with the degraders or not. But as I think as a class of drugs, I've been very impressed by both the safety and the efficacy of these drugs. And of course, I think there's a whole variety of different drugs out there which are, interesting to follow, and which ones of those will finally get approval. And then we'll be left with the issue of how do we use these, and do we start, the same conversation we had about, do you use your best drug first? Is the best drug to use going to be a degrader, or is it going to be a covalent drug? I think that's going to be a long time in clinical development before we get those answers.
Stefan, your views?
Yeah, just, for the sake of a little bit the discussion and entertainment, again, I try to disagree to the little degree possible with my good friend, John. We see the data, and also from personal experience, I'd say we are very impressed with the degraders in patients who failed covalent and non-covalent BTK inhibitors, or in addition to that, even venetoclax. So really difficult to treat patients 4 prior lines in median. Nevertheless, and tolerability is also good. Nevertheless, we unfortunately still see these class-related AEs, these mostly low grade, but yet bothersome bleeding events. What bothers me more and more is also this fatigue that is quite prominent, I think, in the data, and bothers patients quite a lot. So I think, yes, sure, there's tremendous progress, great developments for patients, I think, who would have gone to hospice not too long ago and now achieve a great response to these drugs. Yet there's further room for improvement, I think.
All right, so maybe we'll just finish off with just a question to both of you. If you go home today and go to your next clinic after the conferences, what data have you taken away from the conferences that will actually change your practice? John?
Yeah, that's a good question. I think everything we've discussed today either doesn't change our practice or isn't yet available to change our practice. Certainly, our colleagues in the US are able to use these combinations because one drug is licensed, but of course in Europe and also in Australia, it doesn't work that way. And we can only use the combinations which are together. So I think this was another one of those meetings where what we mostly saw was consolidation of what we already believed. So to my mind, where I'm already using a lot of ibrutinib, venetoclax combinations, particularly for my unmutated patients, I think the data I saw reassured me that what I'm doing is perhaps the best way I can manage these patients at the present time. So I'd go back and say that rather than changing practice, it just reassures me about the practice that I'm already doing. And I think, the same was true for the doublet with venetoclax and obinutuzumab, which I use a lot of in mutated patients. We continue to see data that's, a really good treatment for that group of patients. So nothing new is going to change anything because nothing new came along which has been licensed and approved. I think the one thing that may change, of course, is we don't have a licensing for it yet, but the Americans do, which is, amplify. And will we change our doublet from ibrutinib venetoclax to acalabrutinib venetoclax? But that isn't going to happen immediately because we don't have a license for it yet. And of course, then the big question becomes, will I use a doublet or will I use a triplet? And again, that will largely come down to how it's licensed and what's licensed in Europe and what the data is to support its use. And there's every possibility, of course, is that we'll only get some arms of these studies licensed to use, and that's difficult.
Stefan?
I'd agree. We are in a fortunate situation with a very recent, licensing in Europe of pirtobrutinib to have that available after BTKI and BCL2I failure, with acala venetoclax from Amplify being licensed. So we have many new options in addition to ibrutinib plus venetoclax that we have in Europe for some time now, and obinutuzumab plus venetoclax in addition to the range of continuous BTK inhibitors we discussed that provide, in particular in high-risk patients, very good treatment options. So I think we are quite happy. We are in a very fortunate situation that we have a choice. We can guide our treatment based on genetic and disease-inherent risk factors and on patient characteristics, and obviously on patient preference, which is with more and more patient education obviously gaining more and more importance. And it is good to have that choice to individualize treatment and also to have options not only for the first line, but beyond first line treatment. So I think this is great times. And with the experimental options like the degraders, as we discussed, I think we can be very optimistic that in the near future, this armamentarium will be even broader that we have available.
Sure. I also don't think we can end a podcast without saying that, of course, what the studies also show is the importance of enrolling our patients in clinical trials. And I think all three of us are very wedded to the idea that as many of your patients as possible, for those listening to this podcast, you should put your patients where possible into clinical trials. It often represents the very state-of-the-art patients that, at least some of the patients in the study could receive, but it also gives us the information going forward.
Well, thank you both for an excellent discussion as usual. I've learned so much from you and from your perspective on these key studies. And I think our audience really appreciate your deep and frank insights. I'd like to thank our audience for the attention, and we'll see you next time.